Okay, let's start right away and let's turn to the first case. The first case is that of a medical doctor, actually, who was in training in internal medicine, 29 years old, and she had one child, a very young child at the time, and she was on maternity leave, and during her maternity leave, she came to visit one of my echo courses to train in echocardiography. And she was one of the participants, and as we have it, especially at the beginning, we have demonstrations or at least hands-on training where we train on each other. In other words, everybody has to be a model as well. So this is the association with the title of model. She was an ultrasound model and at the same time learning. So she was examined, and all of a sudden, one of the doctors came to me and said, we have this model, and she seems to have some pathology. Do you think this is okay or normal? So I took this 29-year-old colleague and fellow of mine and took a look at her echo. And this is the echo that I did on her. Okay. This is the peristernal long axis view. And take a look at this peristernal long axis view, and those who've already performed the masterclass and came across a chapter on aortic pathologies will notice that there is something wrong with the aorta. Okay, just to give you a bit of a clue, the problem is obviously the width of the aorta. Remember, usually we compare it also with the size of the left atrium, and the aorta should be approximately at least not more than 1/3 larger than left atrium. And in this case, what we clearly see is that the aorta is very large, or fairly large, I would say. Now, what does this point to? Remember, this is a fairly young individual where we do not expect to have a dilated aorta. Let's take a look at some more views. Well, let's first of all take a look at how we should measure the aorta, because this is the next step we will probably have to do. The normal ascending aorta has a width of 2.5 to maybe 3.5 centimeters, and we'd be measuring it somewhere in the range here. Not at the aortic root, but at the ascending aorta. Okay? The descending aorta should measure somewhere in the range of 2 to 3 centimeters, and the abdominal aorta 1.8 to 2.8. So you see, the aorta gets narrow as we go down. So we should expect a diameter of 2.5 to 3.5 centimeters in her, and in her case, it was 4.8. This is not meters per second, obviously, but millimeters. So the diameter was obviously too much. And the other thing I want you to take a look at is the shape of the aorta. Normally we have the aortic root, and then we have a kind of an indentation, which is the sinotubular junction, and then we have a narrow part, which is the ascending aorta. In this case, it's almost like a sausage. You can see that the aorta has the same width at the root and also at the ascending aorta. And this is always very suspicious that the diameter is enlarged and that there's some form of dilatation or aneurysm. Okay, so the diameter was 4.8 millimeters. Now, what next? The next step I did was obviously to look at the aortic valve. And as you will probably all agree, clearly the aortic valve has 3 cusps, right? We have the right coronary cusp here. This here would be the acoronary cusp, and this would be the left coronary cusp. Just for review purposes, how do we distinguish the 3? Well, there's a little trick that you can do, and the nice thing about it is that we can use this shame that I will present to you in all modalities. In other words, you can use it if you perform TE and if you perform transthoracic echocardiography. The leaflet or the cusp that is located in proximity to the right ventricular outflow tract is always the right coronary cusp. The cusp that is close to the intraatrial septum, which you see here, is the acoronary cusp. So you can remember neither right nor left is acoronary. And the one who is located more towards the pulmonary artery and to the left atrium is the left coronary cusp. So this is how you can tell which cusps you have, but the main issue in this patient was that the valve is tricuspid. Okay? This is the 5-chamber view, and what you see here is some degree of aortic regurgitation. Okay? I just got a question in from Philip, and he asked if this could maybe be a bicuspid valve with RAFI. Well, actually, no, because if we go back to this image, you can see that the separation between the cusps is complete between all 3 cusps. But you're right, it's sometimes very difficult to tell if a valve is bicuspid with a raphe or if it is truly bicuspid or tricuspid. Okay, so this is the aortic regurgitation, which I would probably grade as, I would say, maybe mild to moderate. And the reason for aortic regurgitation is probably pretty obvious. The reason is the dilatation of the aorta. Because if the aortic root dilates, you can expect the cusps to separate from each other, some degree of aortic regurgitation. And the typical finding you find in these patients is that the jet is more central. So the origin is central and also the jet direction, which it is in this case. So mild to moderate aortic regurgitation with no volume overload because the left ventricle is not dilated. Okay, so these are the findings, the key findings in this patient. One other thing that I really want to show you, let me go back to this one image here. Oops, okay, let me go back here. Okay, this image shows you another little finding in this patient. If you look at the mitral valve, do you see any pathology here? I guess you should, because this is mitral valve prolapse. You can see that both the anterior leaflet and the posterior leaflet prolapse. The valve is not very thick, so it's not a very heavily myxomatous mitral valve, but nevertheless, there is mitral valve prolapse, but there was no significant degree of mitral regurgitation. Okay, now we've seen the key images in this patient, and I want you to answer the following question now. And the question will come up on your screen right away. What would you do? Select one of the following possibilities. Would you either simply ignore the finding and say, okay, so what? You have a dilated aorta, but that does not make a difference. Would you center the CT maybe to get more information about the aorta? Would you look for other findings, maybe physical findings or ECG or who knows what? Or would you center the surgery because you think, this is maybe dangerous to have and this should be corrected? Or would you think that maybe a TEE study would provide you with more information? Okay. I'll just give you a few more seconds to answer. There's no risk, so we cannot tell what you're answering if you're wrong and right. And as a matter of fact, there is never only one correct answer. Okay, I think we'll close the poll in a second. Okay, close the poll. And so the answer is that most of you would probably send her to CT. And some of you think you should look for other findings, and others would perform a TE, but most of you think you should send her to CT, which is certainly something which is true. And I would probably do as well, and I actually also did. But on top of that, I did want to know if there are maybe other findings, and so I kind of asked a question. But okay, this is the aortic root. I forgot to show you that before. The aortic arch, which is normal in size, and I did not have the impression that there was any form of dissection. But I asked her a simple question. Do you have any other abnormalities, especially with respect to your joints? And this was the interesting finding. She said, yeah, you know, my joints have always been very flexible, and I could just bend them back just like the fingers that are bent back on this image. So this was a very peculiar finding, but in a way, it does also look as if there is maybe a connection between the joints and the aorta. Think for a second. Can you come up with an idea? Okay, in the meantime, I'll just answer a question or a comment actually from Philippe, who thinks that we should also look at the aorta and check for aortic coarctation, which is completely true, because very often you will have dilated aorta with coarctation. We did that. She did not have it. There's just one finding that would not be fitting perfectly to this combination, because then you would usually also have a bicuspid valve. In any case, what she actually had was, and we could confirm this, she had a syndrome called Ehlers-Danlos syndrome, which is a disease very similar to Marfan disease. It's a connective tissue disease where patients have hyperflexible joints. You can sometimes pull the skin similar to the way is pulled in this dog. There's typical facial characteristics, and there is a subtype which has vascular involvement and where you do see aneurysms of the aorta, but not only of the aorta, but also of other vessels. So there was a high suspicion that she does have Ehlers-Danlos syndrome, and as a matter of fact, we confirmed that with genetic testing. She had type 4 Ehlers-Danlos syndrome, which is the vascular type, which is the one that causes dilatation and aneurysms. And here you see the mutation. Okay, now, how did the story turn out? Well, actually, a very tragic thing, because I told her that she needs to get a CT done, and she got a CT done, and I met her at the hospital and said, what was the result of the CT? Well, the aorta is definitely dilated, but I was told it was okay, and I should just get a follow-up check maybe in a half a year or so. Even though I talked to the radiologist, he said, well, this is something you should not joke about, and you should maybe go back to me and get another opinion on what there is to do, and maybe send her to surgery. But she actually ignored the fact. She just did not want to know anything about the disease. And so what happened was I lost track of her for, I think, a year and a half or so. And then, unfortunately, she got pregnant again. And towards the end of the pregnancy, she started to have all sorts of symptoms as chest pain and whatever, and she was admitted to the hospital. And on the same day, in the evening, all of a sudden, she collapsed and had cardiac arrest and died. Why? Because she had aortic rupture. So a very, very tragic story that I must tell you. But the key thing to remember here is that patients who have a dilated aorta are at high risk of aortic rupture, and especially those patients who have Ehlers-Danlos syndrome. Those, and also the patients who have Marfan syndrome, should probably go to surgery at an earlier diameter of the aorta already. Let me just show you a few other images of other patients so that you get a bit of a feel of how dilated aortic or the aorta can look. Here is a patient, again, with a dilated aorta. In this case, the root is not so much dilated. You still have the sinotubular indentation here, but the ascending aorta is dilated. In this case, it was, I think, in the range of maybe also 5 centimeters. What you should do in these patients is you should really try to assess all the portions of the aorta and measure it both here at the annulus, at the aortic root, at the sinotubular junction, at the ascending aorta, and also take a look at a suprasternal view to see how big the aortic arch is. So let me just go on and show you what this patient had. Well, this patient had a bicuspid valve. Let me go back to this parasternal long axis view. You can almost assume that the valve is bicuspid here already because you have doming of the valve, you see? This is a very suspicious finding that points to a bicuspid valve, but to really confirm the presence of a bicuspid valve, you need to take a look at the short axis view. And here's the short axis view. Clearly, there are only 2 cusps. This is a bicuspid valve. Now, what is the association between a bicuspid valve and the aortic root? Simple. It is a syndrome, actually. In patients with bicuspid valves, you have a structural abnormality of the aorta, and this structural abnormality leads to dilatation of the aortic root and the ascending aorta. So very frequently you find the combination of the bicuspid valve with aneurysms of the aorta. And why is this so important? Well, let me just show you this patient here. This is a patient we saw very just recently, just a few days ago, or actually a few weeks ago. This is a patient who was operated for aortic regurgitation. He had a bicuspid valve, and here you see the mechanical valve implanted here in the aorta. But what he also has is he has an aneurysm. Now, the operation was performed, I think, 4 or 5 years ago, and now, 5 years after that, what he has is a very, very large aorta. As a matter of fact, I haven't seen many aortas that have such a large diameter. It was 8.5 centimeters, so a huge, huge aorta. The problem here is that it is a progressive disease. Now, if you don't operate these patients, especially if the aorta is, even if the aorta is dilated only in the degree of maybe 45 millimeters, you will have progressive dilatation of the aortic root, Even though you solved the problem of the valve, you did not solve the problem of the aorta. So this patient had to be reoperated, and I just saw him today. After operation, everything went fine. He had a tube graft. The only problem is his left ventricle function, for some reason, is not normal now. I will just have to see how this turns out. But nevertheless, I think this problem could have been solved at the first operation. He should have had aortic root implantation or replacement as well. Okay, this is the same patient again, just to show you that we can also diagnose a dilatation of the aorta in a apical long axis view. This is the mechanical valve. This is the aorta here and here. Okay, and the little bubbles you see here are nothing else but cavitations. This is a very frequent finding that you see in mechanical valves. It's a phenomenon which is associated with the physics of ultrasound and the mechanical strain on the red or on the blood cells, which causes little gas explosions. You might have more of these gas explosions or cavitations if patients have some form of dysfunction of the prosthesis, which was not the case in this patient, however. Okay? So how high is the risk of rupture? The risk of rupture increases with the diameter of the aorta. And in the ascending aorta, if you have a diameter of 6 centimeters, the yearly rupture rate, the second death rate, is 15.6%, which is very high. So we cannot wait for a diameter to be 6 centimeters. We certainly have to operate these patients earlier. And there are certain co-founding factors which kind of make the whole thing even worse, especially if you have additional aortic regurgitation, which puts a certain strain on the aorta, or if you have hypertension. What are the OR indications for the ascending aorta? First of all, if you have symptoms, but this is never really the case because patients don't have symptoms if they have pure dilatation of the aorta. The only thing you will see symptoms, however, if they have dissection. I just got a question in from Heiko asking if in bicuspid valves, if the orientation, as we see it in this patient here, let me go back to this bicuspid valve here, sorry, if it is always in this orientation. No, as a matter of fact, not. There's many different variations. You can sometimes have it horizontal, vertical, or very frequently you have a diagonal like this. I can't remember exactly. There's a publication somewhere in the literature which actually states the percentage of each orientation, which is not really of importance from a clinical perspective. But yes, there is a high variation in the way the bicuspid valves are oriented. Okay, but let me go back here. Okay. So the indications are symptoms. The second thing is an end diastolic diameter of the aorta in the range of 5 to 6 centimeters, which is an absolute value, but even better than to use the absolute value is to index it by the body surface area, because obviously large people have large aortas and small people have small aortas. And the aortic diameter also increases with age. So the index of 2.75 per square body surface area would be the cutoff value for operation. And another thing to look at is how quickly does the aorta actually expand. One thing one should always do is to monitor these patients, especially at the beginning, very closely, and then you can kind of increase the intervals, and in between also perform CT scans, because the CT scan does have its advantage, especially in visualizing portion of the aorta which you cannot see with transthoracic echo. Coming back to our patient, well, our patient had 4.8. And as Guillermo correctly stated, this is at itself probably also an indication for operation already. Why? Because the diameter 5.6 is for patients who do not have any associated connective tissue disease. In her case, she did have a connective tissue disease, Ehlers-Danlos syndrome, so the reason for operation, or the indication for operation, would have been given at the time. But as stated, she did not want to hear anything of operation and kind of neglected her own problems. Okay. Other reasons to operate patients would be if you have evidence of dissection. If you have aortic valve surgery scheduled, for example, for aortic valve replacement, and the diameter is 4.5 at the time, or more than 4.5, you also have to operate on the ascending aorta. Remember the case I showed you previously. And if you have aortic root disease, this is the case with our patient if the aortic diameter is between 4.5 and 5. Okay. Let me come back now. Or there's one more question from Heiko, who asks if the shape or the form of the aneurysm plays a role in the indication for operation. Well, not so much, but it does play a role in how the aorta can be repaired. First of all, you have to take a look at how high does the aneurysm reach. Does it reach all the way into the large vessels? Does something need to be done there? It's always a question of what about the coronaries? And it's always a question of should you use a simple operation where you simply replace the aorta with a graft, or can maybe even reconstruct the aorta? This is something which is also being done. And how does the native aorta look? If you can maybe use the native aortic valve, if it's still okay, then you might not have to have a prosthesis. So you kind of resuspend the native aortic valve in some form of Dacron tube, or maybe even to the native aorta. So there's a different a way of going about, and I mean, I'm not a surgeon, so I'm not really the one to ask this question, but basically, yes, it does play a role, but not for the indication, more for how to solve the problem.